Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the third episode of our mini-series, Psoriasis and Skin of Color Unplugged, supported by an educational grant from Janssen Scientific Affairs. Thank you for joining us for our third episode, featuring our host, Dr. Mona Shahriari, and her guests, Dr. Andrew Alexis and Jennifer Soung, as they discuss treatment and clinical study of psoriasis in patients with skin of color.
Hello, everyone, and thank you for joining us for this exciting podcast. We're going to be focusing on the gaps in skin of color representation in clinical trials and what new innovations are being done to really help with the equity, diversity, and inclusivity in our clinical trials for plaque psoriasis. My name is Mona Shahriari. I'm an assistant clinical professor of dermatology at Yale University and the associate director of clinical trials at CCD Research, and I'm joined by my colleagues and friends, Dr. Alexis and Dr. Soung. I'll let them introduce themselves.
Hi, I'm Andrew Alexis. I'm a dermatologist in New York City. I'm a professor of clinical dermatology at Weill Cornell Medicine in Manhattan, and it's really a pleasure to be here.
I'm Jennifer Soung. I'm a dermatologist in Santa Ana, California, and director of clinical research at Southern California Dermatology and a clinical faculty at Harbor UCLA.
Thank you guys both for being here tonight. And it's really an exciting topic, I think, for us to talk about because all of us are clinical trialists. We're heavily involved in improving skin of color representation in so many arenas of dermatology. But let's just start by talking about historically, has skin of color representation within our clinical trials been an issue? And really, what steps are we taking to help improve that? Dr. Alexis, I'll have you start us off.
Yeah, this is a great way to start our conversation because when we think about historically our representation in clinical trials, if you look at the demographics of any of the leading clinical trials in psoriasis in particular, for many years we'd look at that demographic table and see somewhere around 85% or so of the representation being individuals who self-identify as white, leaving the very small percentage of the broader mix of racial ethnic groups and skin types that we see, of course, in our real world practices. And so there have been these data gaps and knowledge gaps in terms of understanding aspects of psoriasis in patients with the broad range of skin types and backgrounds that we call skin of color. And so it's exciting that and I know we're going to be talking about it a little later, but it's exciting to see some of the shifts in our work in clinical trials that are helping to address some of these knowledge gaps.
I'm also going to add that not just kind of diverse skin tones, whether it's racial, ethnic backgrounds, there's also been a lack of diversity in gender as well. So when you look at some of the phase 3 pivotal trials, you'll also see that it's majority male patients, 80 to 90% male patients with fewer female patients as well.
And it's interesting you brought that up because it wasn't until 1993 when women were included in clinical trials, period. That's not that long ago. I know that counts in my generation and our generation as a whole. So that's a very important point to bring up. Now, Dr. Soung, I know that you work in an area where you see a very diverse population. And what are your thoughts on the types of clinical trial sites that our industry partners have used in the past in terms of them being able to enroll a diverse population?
Right. So I really think that you have to start with where you choose your clinical trial sites and investigators, right? Do these investigators have a relationship with these patients who are non-white? And that's why I'm located in Santa Ana. My patients ask me all the time, what are you doing here? It is a largely Hispanic community where I see a diverse range of skin tones. I see Hispanic, I see Asian, Southeast Asian, Black patients. And I think that when you're looking for a population that is non-white, you also have to go to their communities. And you have to be in their communities where you can develop a relationship or have some sort of trust. Because in a lot of these communities, patients want to see doctors that look like them. I mean, I don't look like them, but I speak Spanish. And so that's one way for me to connect with my patients.
I think that's actually a very important point, because if we keep going to the same clinical trial sites expecting to get a more diverse population, I don't think it's going to happen. So really helping improve the diversity of not only our sites, but also our investigators will definitely go a long way. Now, I know there's a lot of movements from the FDA to increase diversity in clinical trials. And I think sometimes we think of that as just a numerical number of patients that will be in our trials that represent a certain skin type or a certain gender or background. But is it enough to just increase the numbers? Is that going to really help us achieve the goal that we're trying to achieve? What do you think, Dr. Alexis?
Well, I think, you touch on one aspect of some of the current trends and efforts in research to be able to conduct studies that give us data on populations that are more reflective of the U.S. population. So if we have business as usual, sort of historical approaches to clinical trials, there were large gaps in our understanding of specific patient populations that tended to be under-enrolled. And so efforts like the FDA mandates to include a diverse patient population, we will be able to have study populations that are more representative of our real world population. And I think that's a step in the right direction. But to answer your question, is just sort of looking at numbers enough? I mean, I think it's a much more complex issue. And the Skin of Color Society actually had a very important summit in December at the end of last year to discuss some of the concepts of population descriptors. How do we even describe the diverse patient population? The descriptors that we've used up until now have major limitations. Self-identified race, Fitzpatrick skin phototype, et cetera. They all have limitations. And so we're coming to a point where we're trying to come up with more accurate, more objective, more inclusive descriptors of our very diverse population.
And I really like that, because I think the better we are at using terminology that's inclusive, the more likely we are to incorporate individuals that may not have been included in the past. Because I know myself, I'm of Middle Eastern descent, I'm skin type 3, and many times the way they describe skin of color in these studies, I would be excluded, even though my skin doesn't respond the same way as someone who's Caucasian potentially. Now, beyond just the number of diverse patients that we can increase in our trials, what about the journey of the patient with skin of color can potentially impact their ability to participate in a clinical trial? Dr. Soung, what are your thoughts?
You bring up a great point, and I think I touched upon this earlier, is that a lot of our patients who are identified as non-white also don't have as good of access to healthcare. So I think a lot of these issues of underrepresentation in trials starts much earlier in the process. Are there doctors who look like them? Are there doctors who are diverse? Is our medical school diverse as well? And so that you're also building a community of healthcare providers that can relate to these patients or are culturally sensitive. When we talk about giving doctors the right tools to be able to take care of patients of diverse backgrounds, this is all tied in together in order to ultimately take better care of patients and increase access to care. So what happens is a lot of these patients may wait longer than usual to get for example, their psoriasis treated, because they're often maybe not trusting the healthcare provider, or may not take a lot of time off from work to be able to go see a dermatologist until their skin gets so bad. They're like, I can't work now. So now I really need to go get my skin taken care of. So we often see there's a delay in treatment, or maybe differential access to treatment, or more severe symptoms by the time that they present to the dermatologist.
Okay.
Yeah, those are great points. If I could just jump in and piggyback off of one of your comments, I think another dimension to to the factors that lead to delays in diagnosis has to do with low public awareness among diverse communities about psoriasis itself. I find many of my patients from various backgrounds may not really know anyone else that in their community that they know of publicly has psoriasis. They don't, if they go to their search engines or other sources of information, they don't really see any images or pictures of people with psoriasis that resemble their own background. And so these two, among the many other factors that you've mentioned, that this also can contribute to this sort of lack of trust in the system and not really knowing, do I really have this condition? Even if a doctor or healthcare provider says they have psoriasis, they might still doubt it if they don't see any pictures or features of other patients that look like them. And so having images and educational materials that are more representative is another factor that I think that is going to be helpful.
Yeah, I couldn't agree with you more. Whenever I educate my residents, I love to do a Google search for psoriasis and then take a snapshot of that first page of Google. And it's surprising the lack of representation of diverse skin tones that we see. But like you said, if I'm a patient and I don't see my skin represented there, I may not call the specialist, or even if the specialist says I have X disease, I may doubt them. And there's already that level of mistrust in the system as well. Now, I know, Dr. Soung, you mentioned earlier that you live in an area where you speak Spanish, but you're not necessarily someone of that Hispanic origin. And do you think the language barrier piece plays a role in your patients' ability to participate in a clinical trial, or some sites may not necessarily want patients who can't speak English?
I think absolutely. I think it's just another way of trying to establish a relationship and build trust with your patient, is that if you can speak their language, they want to understand what's going on. They want to feel comfortable in a clinical trial. And that's one of the very first basic needs, is to be able to understand and communicate with your doctor, to be able to form that relationship. So I find that it's really helpful for me. I can't speak all languages, and I do speak kindergarten level Mandarin, so I do my best. And again, whenever you try to connect with your patient, and even if you don't know their culture, just being open and curious about their background, and even asking, I'm not familiar with all of the cultural traditions that may influence your skincare. Can you tell me more? They are just so thrilled that you are open to listening to them.
I actually love that final point, because getting and delivering culturally competent care is, I think, something that a lot of our patients struggle with. And having someone that spends the extra 2 minutes to just ask them about what their expectations are from the visit. And if maybe things aren't going in the right direction, you just take a step back and really see how you could do better. I think those little measures can make such a difference in the life of the patient that's sitting in front of us. But I think we did a good job of kind of looking at the landscape and some of the gaps that currently exist. But what do we think about what's being done to close the gaps? I know we had touched upon improving diversity in clinical trials. Are there any other points that you guys think we could do better in terms of making our populations in trials more diverse?
Well, I really think it comes down to increasing, for me, access to care. Like I mentioned earlier, a lot of these patients don't have access, or there's mistrust in doctors, and so they're not sure where to go to, or even to trust the medication. So for them, seeing that these medicines are actually tested in patients who are like themselves is so important, because if we're only looking at one population of patients in trials, we may not know how does it behave differently in other populations. So again, I think it's about building that trust, whether it's the healthcare industry or pharmaceutical companies with patients and communities.
I think the trust piece, especially given the history that we have in the United States with experimentation, is something that we do need to take seriously. And a lot of times that trust may not happen in the first visit. It may not happen in the third visit, but we just got to be adamant and continue to talk to these patients to help them understand that we care as much as they do about this relationship, and really finding a solution to what's going on. But Dr. Alexis, I know you've been involved in a lot of these newer clinical trials that have had a focus on skin of color, some topical agents, as well as some systemic agents. Why don't you just tell us what the landscape has been like in terms of improving that diversity?
Yeah, absolutely. When I started my career, I guess I won't say when that was, just not to date myself. But let's just say that there weren't, when we tried to answer questions about differences between different racial ethnic populations in psoriasis, we looked to the data in a post hoc fashion and usually ended up with very, very small sample sizes, making it difficult to draw any meaningful comparisons. And then over the past, let's take the past 3 years or so, we've seen some studies come to fruition that are open label and small and single center, related to patients with skin of color. And then finally, the largest, first of its kind, placebo-controlled trial with guselkumab in patients who identify as any of the racial ethnic groups that beyond white, and had objective measurement of Fitzpatrick skin phototype, using instrumentation to objectively measure the patient's skin tone, and other novel approaches that are particularly relevant to the diverse spectrum of patients was conducted. And this is the study that we're all familiar with, called the Visible study.
Yeah, I think that study is near and dear to a lot of our hearts because it really was the first time we looked at patients in a completely different fashion. But I think the benefits of the trial really go beyond the endpoints that they were looking at. They were focusing on, obviously, the safety and efficacy of guselkumab in patients that identified as non-white. But what additional educational points, Dr. Soung, do you think this study is giving us?
Right, Dr. Shahriari. We all know actually that Tremfya works in this patient population. And I know all of us here treat patients of diverse skin tones. And so more importantly to me, it was symbolic of lots of different things. One, creating a new network of clinical trial sites and investigators to be able to recruit these type of patients. And then subsequently figuring out how are we going to study diverse skin tones, right? We briefly mentioned some old tools that have been really based on how white skin responds to sunlight or a sunburn, like the Fitzpatrick type. So how are we going to kind of meld our current terminology system with identifying different skin tones? So one of my really neat things I think we learned from this study is using the colorimeter to measure the melanin content and categorize these patients. And what we learned is that patients who identify themselves as non-white can cover the spectrum of type 1 Fitzpatrick all the way through type 5, where sometimes traditionally we may think, oh, if you identify yourself as non-white, then you must be at least a 3 or higher. But that is not true. And we saw people of all sorts of racial ethnic backgrounds have that broad spectrum of 1 through 5. That's one thing. And I don't want to steal all the points, but the second is how do we truly evaluate diverse or darker pigmented skin using clinical trial tools that we've typically used before, where, for example, in psoriasis, whether we're using PASI or PGA or IGA, we look at the degree of redness. Well, now in darker skin tones, that is not quite the same because it can look more purple or violaceous. So how do we incorporate that into our current scales is different for each investigator. So I think that these were originally, again, invented in white skin. So how do we adjust going forward, looking at darker skin tones especially? And then the last point is really the post-inflammatory pigmentary alteration or dyspigmentation. So some patients can heal with lighter skin or darker skin. And to patients, this is just as much a part of their psoriasis as the plaques themselves. So we have great medications that can clear the plaques and there's just not been recorded in a study or a systematic way looking at how does that post-inflammatory dyspigmentation heal.
Those were excellent points. Thank you, Dr. Song. One thing actually I really like that you touched upon was the variety in Fitzpatrick skin types within even a specific ethnicity. And I think that's why when a lot of studies are doing these post hoc analyses and they're categorizing people based on specific races or specific Fitzpatrick types, we have a tendency to miss some of our patients when we do that. So that's not the most inclusive way to really be looking at skin of color. When you don't have anything else, that's obviously going to be the best that you have and you work with what you have. But I think this study really shows us the broad nature of patients that are out there that identify as non-white and how we need to keep all of their needs in mind and really have a more broad approach to those individuals. Now, I know you touched upon the post-inflammatory pigment alteration. I know, Dr. Alexis, you and I have talked about this in detail in the past. What is your approach usually with these individuals to ensure their expectations are met, but also we make some impact on the pigmentary changes?
Yeah, I will sort of emphasize the point of how post-inflammatory pigment alteration is often just as important to the patient as far as their experience and their journey with psoriasis as the elevated, the scaly erythematous plaques and other features of psoriasis might be. So in the very first consultation, will set expectations as to what we expect the different stages or evolution of their treatment to be. That first, we're going to see improvements in the elevation, scaling, erythema, etc. of the plaques. But then there will be areas that we're going to be lighter or darker than their normal skin tone. And it will take several weeks to several months before that clears. And the more effectively we control the underlying cause of the pigmentary changes, psoriasis in this case, the better outcomes we'll get in the long run. Because if we don't control the underlying psoriasis, what happens is if we just go after the pigment, a new plaque emerges, causing a new patch of pigmentary alteration. And then it gives the patient the perception that they just never get better. So that's one, set expectations and lay out the expected time course. Number two is I will proactively, in some instances, proactively treat the post-inflammatory hyperpigmentation once the psoriasis plaque is completely resolved. And for that, I might leverage topical retinoids, topical hydroquinone products, triple combination hydroquinone therapy with the retinoid and corticosteroid, non-hydroquinone based therapies, including azelaic acid, just as some examples of things I might incorporate into the regimen once the psoriasis has been adequately addressed and well controlled, and we're left with just hyperpigmentation.
Well, and what I love is you gave me so many different options on how to treat the post-inflammatory changes, which I think really shows us there is no one size fits all, and we don't have that magic cure for the post-inflammatory changes. So I think each of us kind of tries to customize the treatment to the person sitting in front of us. But I, just like you, have a low threshold to consider systemics in these individuals because really prevention is the name of the game when it comes to those post-inflammatory changes. Now, I know, Dr. Soung, you have a very fun way of discussing clinical trials and clinical trial designs. So I'm just going to have you touch upon the visible study, the 2 cohorts, and what really was that overarching design of that trial.
Thank you. So the visible study is its first of a kind phase 3B study looking at guselkumab in 2 cohorts of patients. So the first cohort is what we kind of think of our usual suspects. So adult patients who self-identified as non-white and who had plaque psoriasis. So your body surface area of 10% and PASI score of at least 12. Now, cohort B focused on patients who had primarily scalp psoriasis. So they only need to have one plaque elsewhere on their skin, but primarily had at least 30% surface area of scalp disease, because we often are curious in our patients who may not respond to topical treatment that scalp psoriasis can be just as impactful on the patient's life and may require a systemic treatment. So they looked at 2 arms of patients. Now, the phase 3 trials for guselkumab have already been completed. As you all know, it's been FDA approved for several years now. So this study was much smaller than their pivotal trials. So we're looking at about 200 patients in the trials.
Thank you so much. And I know, Dr. Alexis, we've talked about the impact of scalp psoriasis in our patient with skin of color. I'm just going to have you touch upon why it was so important for us to have this dedicated scalp cohort.
Yeah, I'm very happy that we were able to have this design of the two cohorts, including the scalp, predominantly scalp involved cohort, because we all recognize that when psoriasis involves the scalp, in patients, first of all, in any patient, of course, it can be uniquely impactful. It's a special site in my view. But when we think about nuances across the diverse spectrum of patients with skin of color, let's say women of African descent as an example. So when Black women have psoriasis involving their scalp, taking into consideration the hair care practices and cultural considerations of having visibly scaly plaques in the scalp, it adds an additional burden of the disease that contributes to the quality of life. The post-inflammatory pigment alteration on the edge of the scalp along the frontal hairline, which is quite visible, can also contribute some additional burden for patients with skin of color who are suffering from scalp psoriasis. So for these reasons and others, I think it was very important to have a scalp dedicated cohort, and I'm glad that we were able to do that.
And what I actually found really interesting was when you looked at that scalp cohort, on average, patients had had their disease for more than a decade, but less than 1 in 5 had been on a systemic, which, given how tough it is based on what you just described, using topicals, especially in our women with tightly coiled hair or afro-textured hair or varying hair care practices, I was very surprised by that, which makes me wonder, how well are we treating these patients given the quality of life burden that scalp psoriasis has? So, with that background information, why don't we just go through what this study showed us? What were the pivotal results from cohort A and cohort B?
Sure. So at week 16, in cohort A, in the visible study, guselkumab achieved its co-primary endpoints of investigator global assessment score of 0 or 1, which means clear or having minimal disease, and the second co-primary endpoint of having at least a 90% improvement in the psoriasis area severity index PASI, so PASI 90. So what were the numbers? Well, at week 16, 74% of patients receiving guselkumab achieved an IGA of 0 or 1, and 57%, 57.1 to be exact, achieved at least a 90% improvement in PASI. So that's a quick high-level review of the co-primary endpoints for the first cohort.
Excellent. And I know in cohort B, just to kind of keep it high level, we had about 6 out of 10 patients who were able to get to the endpoint of 90% improvement, as well as clear, almost clear in the scalp. But interestingly, of the patients that met the primary endpoint, about 85% of them had gotten 100% clear. So they were completely clear or had achieved that PSSI of 100. And given everything we just talked about with respect to the burden of scalp psoriasis on these patients, I think that's really huge. And in clinical practice, when you have a patient that can get that clear in a matter of 16 weeks, 3 injections, what does that mean for your patients?
I think it's a highly effective and safe treatment that is convenient for patients. I was really impressed with even the improvement after just 1 injection, seeing that at week 4 we saw an improvement starting that early with guselkumab being an IL-23.
And so I think this trial has so far taught us so much about treating plaque psoriasis in skin of color with guselkumab, but I also think it's taught us a lot of other elements as well about that skin of color patient journey. So Dr. Alexis, what other benefits do you think we've gained so far? I know we've only scratched the tip of the iceberg with the data that we've analyzed.
Yeah, I think we've learned so much already with the visible studies so far, and there's just so much more to learn as more and more data from the study gets released. But let's just start from the beginning. We've now learned some very effective strategies for enrolling a study that is as diverse as the Visible trial. Prior to doing this, many would have thought that this would be a very difficult undertaking, might not be able to actually effectively enroll the types of demographic populations we did enroll, and we enrolled. Not only did we meet our targets, but we even did it in less than the predicted time. So it goes to show the effectiveness of carefully selecting trial sites, educating the principal investigators on best practices for enrollment and for assessments in diverse patient populations. I think the photography approach was very good in that we have both standard photography and polarized, cross-polarized photography to be able to better differentiate erythema from pigment. And I think we're going to learn a lot from that. I think that the use of colorimetry has given us great insights into how to objectively measure patients' skin complexion, and may also be used to differentiate erythema from pigment. And we're going to, I think this will set the stage for future use of colorimetry in trials. The effect of treatment on pigment alteration, one of the secondary, one of the exploratory outcomes. I'm looking forward to seeing data once that's available on that. So this is just the tip of the iceberg. I think we've got a lot that we can learn from this Visible study.
And Dr. Soung, are there any other pearls that you have taken away from this study, or you think we're going to be able to accomplish as we continue to analyze the data?
I'm going to add on to what Dr. Alexis said. I'm really excited to see how that pigmentary alteration dissipates or resolves over time. And I think that it'll really also show us that I've seen in my personal practice with patients is that treating earlier, you will see less recalcitrant dyspigmentation. I think that's one highlight, and really, and the pictures to me mean so much. We've developed this vast database now of patients with diverse skin tones in plaque psoriasis, where, just like you said earlier, Dr. Shahriari, when you Google psoriasis, you just see white skin. So these days, and this is the patient population I have worked with ever since I finished my residency. So I used to not take so many photos, but now I take photos all the time because I want to be able to capture these images to share with my residents or to share when I give other CME lectures, because we don't see them all the time. And it does certainly look different in all populations. So it's one of those situations where I encourage other dermatologists, if you're not seeing what you think is typically plaque psoriasis and it may look atypical, for example, the scale might be thicker or more micaceous or not as erythematous, then don't hesitate to do a biopsy just to make sure you're on the right track.
I couldn't agree more. And I have to say, the number of photos I used to take before this study were high anyways, because every time you'd give a talk, that's the one thing that nobody had photos of. But hopefully this database of 20,000 images will help educate the masses. So those of us in the trenches will just need to take photos of the truly atypical varieties as opposed to bread and butter plaque psoriasis. And I also wonder, maybe down the road in our clinical practices, using a colorimeter may become the standard of care, kind of like you get your blood pressure done, you get your heart rate checked, and then they scan the patient with a colorimeter. Or even maybe you don't have a colorimeter in your office. I know a lot of us don't, but we do have access to cross-polarized light with our dermatoscope. So that's another way for us to better assess the erythema, the post-inflammatory changes. So I think we'll be learning so much more as the data from this trial really get into the hands of clinicians. Now, if you were to leave our audiences with one final pearl, whether it's related to treating plaque psoriasis with systemics like guselkumab, or even just what's a good best practice for treating skin of color, period, what would you leave them with? Dr. Alexis, I'll start with you.
I'd say one key takeaway is to avoid under treatment of psoriasis in any patient, but when it occurs in patients with skin of color, there's the additional sequela of post-inflammatory pigment alteration, which contributes adversely to the quality of life impact of this disease. And so having a low threshold for using a systemic agent, if that's appropriate for that patient, we've got great topical therapies as well for those with more limited body surface area, novel topical therapies that have recently been approved as well. So in 2024 and beyond, we really have very effective tools to get our patients to clear or almost clear, and do that in a way that's much earlier than we have historically. I'd like to see I'd like to see an avoidance of delays in treatments and delays in effectively managing our patients to get those outcomes that we're looking for.
And Dr. Soung, what about you? Any last minute pearls?
I'm going to have to echo you on that, Dr. Alexis, is don't underestimate the severity of disease based on body surface area alone. So it's the same theme, and that's why the cohort B or scalp predominant disease group is so important, is really emphasizing the point that it's not body surface area alone, and that we're really looking at location, impact on quality of life. All of those things come into consideration. So in your patients, it's really, to me, has the patient tried a topical? If they fail the topical, then they're a candidate for a systemic, and taking all of those other factors into consideration, like the dyspigmentation, as well as whether it's psoriatic arthritis or other comorbidities, as well as certain, for example, quality of life factors. When we ask the patient, ultimately, for me, it's about shared decision making and how does the psoriasis impact your life?
I love those tips and tricks. I'm actually going to bring forth one more tip, which is probably very simple, but just undress the patient. I think a lot of times when we see our patients with melanin-rich skin, or even our fairer skin, we have them pull up a side of their shirt, roll up their sleeve. But I think in the patients with darker skin tones, it's so much more important to be able to see all of the skin, so you can see what's normal, what's abnormal, really touch the plaques, use side lighting to assess that induration so you can better diagnose. And I think that simple step might make a world of a difference for some of our clinicians who may find it trickier to diagnose plaque psoriasis in the diverse skin tones. But thank you guys so much for this rich, engaging discussion. I know whenever I listen to the two of you, I learn key pearls that I take back for my clinical practice. But I think what we've really been able to hone in on is there have been gaps when it comes to treating plaque psoriasis across a variety of skin tones. Our clinical trials that have historically meant to be a small group that represents a larger group haven't done a good job of having that small group represent everybody. But now we are on the brink of more diversity in clinical trials, not just in plaque psoriasis, but across the board. But I think the VISIBLE study has really been a game-changing study to show us that, you know what, it is important to prioritize the needs of our patients with skin of color. And besides just understanding the safety and efficacy of the in these individuals, we've learned so much about that skin of color patient journey. So hopefully we can continue to build upon this, because as the population of the United States continues to diversify, it is more important now than ever before for us to become comfortable treating these patients, because let's face it, they're going to probably make up the majority in our practices in the not so far future. So do we have any additional points for our audiences before we wrap up this evening?
I think you said it all.
All right. Thank you guys for joining us. It's been a pleasure.
Thank you.
Thanks for having us.
Stay tuned for our next episode of Psoriasis and Skin of Color Unplugged, titled Patient and Disease Advocacy, featuring the Vice President of Government Relations and Advocacy at the National Psoriasis Foundation, Jason Harris.